Hi, everyone. My name is Tiffany Drummond. I am a patient advocate, public speaker, and ambassador with Endometrial Cancer Action Network for African Americans, or ECANA for short. And I am so happy to have this oncologist, GYN oncologist, in the room today. Me and Dr. Slomovitz go way back, so I know him. So this conversation is going to be one for the books. So before we get started, Dr. Slomovitz, and I let you kind of introduce yourself, I'm going to brag on you a little bit. Is that okay?
Of course, whatever. Don't brag too much because it's probably then it's not true.
Okay,
Not true.
so don't listen to him, guys. Okay, so Dr. Slomovitz is the director of gynecologic oncology and co-chair of the Cancer Research Committee at Mount Sinai Medical Center at in Florida, in Miami, where it's nice and beautiful and breezy there. And you are also a professor of obstetrics and gynecology at Florida International University. Are you still doing that too?
Yes, ma'am.
You also are, and where I know you the most from, you are a member of the board of directors for the GOG Foundation and the Uterine Cancer Lead for GOG Partners. And I could go on, but I feel like I don't want to brag too much, but I want you to do a humble brag about yourself and kind of just let us know about who you are and how you got to this level and your passion for endometrial cancer awareness.
Yeah, no, thank you for that introduction, Tiffany. So I'm Dr. Brian Slomovitz. I'm a gynecologic oncologist. As mentioned, I serve as the director of gynecologic oncology at Mount Sinai Medical Center. Recently appointed deputy director of the Uterine Cancer Center there. So I'm excited to have a new role there as well. And within GOG Partners, I'm the uterine cancer clinical trial lead. You know, we're extremely passionate about filling unmet needs for the treatment of endometrial cancer. We know the number of deaths due to this disease is going up. We know the incidence is going up, and we need to do better. And I'm super excited that finally we're spending more and more of our time, more of a focus on the treatment of endometrial cancer.
Yes, and I'm glad you said that about the incidence and mortality going up because I recently saw on the news, which is good news, that cancer overall, but of course, when you're doing a news segment, you only have 1 minute to kind of get all this information in. And they were saying how the 5-year overall survival rate is going down. But it was a
Yep.
very generalized conversation, and I'm like, I know that to not be true in endometrial cancer.
Not endometrial cancer, it's not true. That's right. Spot
Right.
on.
Exactly. So before we get into this, because we are the Endometrial Cancer Action Network for African Americans, and I think that's a very specific conversation that we need to have. But before we get there, do you think that you can give us what is the general landscape right now of endometrial cancer? As you kind of mentioned that it's on the rise, but in terms of this trend, is there any reason that you think and that you've seen in the data that may support why this trend is going upward?
Yeah, some of the reasons are known and some of them we're still trying to figure out. But one of the big things is the obesity pandemic. We know that obesity is one of the drivers of the disease. Fat tissue makes estrogen. Estrogen is sort of a fuel for endometrial cancers. So that's one reason the amount of obesity in this country continues to rise. In addition, there's some other biologic factors that we're finding more and more, particularly in the high-risk histologies. And as we talk, we'll say, the high-risk histologies, we're seeing them more and more in Black women. Mm-hmm. So we need to better figure out why they're going up. And then we need to better figure out ways to disrupt that curve and prevent that from happening and actually have it go in reverse to decrease the incidence.
So let's talk about the therapeutic revolution of endometrial cancer. And I can just say as a clinical research professional, just in the past 10 years, I think we've come very far in terms of how we treat endometrial cancer. And so we've seen this shift in how it is treated, moving far beyond traditional chemotherapy. So can you talk about the latest, and I know for you, the most exciting treatments, like immunotherapy, for many of you out there who may not be familiar with that term as it relates to endometrial cancer treatment therapy, and how are they changing the outcome for patients?
Yeah, no, thank you for that. I think, it's crazy. Our first FDA approval for endometrial cancer was like 1973 with hormonal therapy, progestin therapy. After that, we didn't have an FDA approval for endometrial cancer. It was like 45 years. It was amazing. The apathy, the lack of respect, really, that we showed this disease. Now, over the last several years, it's been a revolution, right? A revolution in the treatment options for this disease. What do I mean by that? Immunotherapy. We learned through a series of trials that immunotherapy is really indicated for all women with endometrial cancer at some point along the course of their treatment, which is really We're seeing benefits in progression-free survival and recurrence rates. We're seeing benefits in overall survival, particularly in some subgroups of women. We're seeing more of the C word, cure, which is remarkable.
Right.
So we've added immunotherapy, and now we're into I'll say our next revolution. There's a new class of drugs, something called antibody drug conjugates, which we're learning more and more. They're going to be active in this disease, and they're going to be incorporated somewhere along the line of therapy, whether in the recurrent setting or in the newly diagnosed setting, as a great treatment option for the patients as well.
And while I have you here, and I don't want to stick on immunotherapy, but if you could give our listeners out there just a general overview of what immunotherapy is, because I think it can be confusing when your doctor tells you, oh, we want to add immunotherapy to your treatment, and you may get the impression that it's chemo. So can you just give us what that looks like, immunotherapy, as part of your cancer treatment?
Yeah, and that's a great question, because people like the word immunotherapy. They don't really know what it means. So immunotherapy isn't like a chemotherapy that kills a cell. What immunotherapy do is it stimulates your body to activate the immune system more, to recognize things that shouldn't be there. And by stimulating or activating the immune system, it helps the body get rid of these things. So it's really a way to enhance the body's ability to fight off things that shouldn't be there. I like to refer to it as hot tumors and cold tumors. Hot tumors respond very, very well to single agent immunotherapy. And they always worked in immunotherapy from the earliest studies. It's the cold tumors we've learned over time that immunotherapy works, but we're just giving it with some agents to turn a cold tumor hot, to make it more responsive to the immunotherapy.
Got it. That is perfect. Thank you so much. And I do feel like I tend to find that is one factor that makes people hesitant about wanting to just add another drug or agent to their therapy. So now let's get into what I'm really here and what I brought you for and stalked you for. I don't know if you all know, but I am stealing Dr. Slomovitz from a conference. It's okay though. So let's talk about the stats here, Dr. Slomovitz. And I know as a patient advocate, when I go into these spaces with pharma companies, other researchers and doctors, my concern and my topic, which has been for probably the past 10 years since I've been really passionate about this work, is can you explain why there's this mortality gap? And I didn't realize that there was a gap until my own mother was diagnosed with endometrial cancer at a late stage in her early 60s. So Black women are diagnosed with a more aggressive subtype of endometrial cancer and face significantly higher mortality rates than white women. That is the statistical fact. And from a clinical perspective and the knowledge that you have and gained and your research that you're doing as well, what drives this disparity? And I know for those of you who aren't science nerds, we still need to learn about this information. That's part of patient education. Is there any tumor biology, delays in diagnosis, systemic disparities? Like, what is your take on the mortality gap?
Yeah, and bottom line, just to highlight what you said, Black women with endometrial cancer are twice as likely to die from their disease from white women. And that's the statement we've always been afraid to say for all the wrong reasons. We have to say it because, as you know, the best way to solve a problem is first to recognize the problem, and that's the problem. Right. So the question specifically that you have is why? I think it's multifactorial. You alluded to your answer, maybe a little bit of access to therapy. Well, that may be a role. We're learning more and more that it's not just that. That maybe that's one of the reasons, but there's other reasons. We really need to figure out, when we look at the cases, those patients with what we call high-risk endometrial cancer histologies or cell type more likely occur in Black women. So there you go. Number one, we're seeing more aggressive subtypes in Black women. So that leads to the fact that maybe the biology of the disease is different in Black women than it is in other races, which is an important thing to figure out, to know more research on, because if we could figure out the biologic difference, then maybe we could intervene and interrupt that axis. Third, and equally as important, is response to therapy. Maybe it is similarities in the cancers, but maybe Black women are just responding differently to these therapies, and that can result in a decrease in outcome, a worsened outcome, a decrease in overall survival. And then there's some not mutually exclusive reasons. One of the reasons may be being socioeconomic status.
Mhm.
Not just Black women, but all patients who are of a lower socioeconomic status. They don't have time to go to their doctor as much. They don't have maybe the money to park in the parking lot at some of their doctor's offices, or they may not be able to leave home for child care reasons and things like that. So those are another reasons why there's some determinants of health that we need to overcome.
Right, absolutely. I'm so glad you brought all of those things up. And I feel like that's where the conversation is going to continue literally until there is a cure for endometrial cancer. Because one, clinical trial representation, which is where I'm going to go with my next question, where this leads to. And I know we're both passionate about clinical research. And one of the things I think that's a barrier is lack of participation in clinical trials. And, I think it's a conversation to have, because when we're talking about diversity in clinical trials, and you want to be ethical. And so I think the thought process, and this is me as a patient advocate speaking, is if you say, well, I want to do a clinical trial specifically on Black women with endometrial cancer, that it almost seems exclusionary, which I don't think to be the case, but I can understand why somebody may think that. but until we get there, I do think that even having more representation on all clinical trials is just going to be better for us to understand. And I think right now we're hovering around 5% or less of,
Yep.
Black women that are on these clinical trials, Black and brown women. And so let's kind of talk about clinical trials. And I know that you've been principal investigator in clinical trials. You've written many publications on this topic as well, endometrial cancer as well. So we know, you and I know, that many of these cutting edge therapies, and including those that have been recently approved, many don't know that these were part of clinical trials for probably the past 10 years before it got approved. Black women have been deeply underrepresented in these trials. And how is the GYN oncology community, specifically the medical community, working to build trust and increase diversity in clinical research, and to be able to allow this access to innovations that may not be available to the public for years to come? I know that was a loaded
Yeah.
question. Some of it I can ask anybody. It's you.
Wow, that's I could sit here all afternoon answering that. So let me start off a couple of points. In order to increase Black women representation onto trials, the first step is to overcome some of the biases, some of the tragic biases that were done historically. Historically, there were some inappropriate trials that exploited women of different races that should never have happened. And as we go through time, those are some of we've had difficulty overcoming those biases. We're getting there more and more, but still, that's one of the main reasons to make sure that the patients we treat are comfortable with the level of care we provide. That includes the option of clinical trial enrollment.
Mm-hmm.
Secondly, sort of what I alluded to earlier, but it holds true here. Going on to clinical trials requires time, energy, being away from work, being away from your kids, and it requires the ability to financially support those aspects.
Right.
That you can miss work, or you can miss your childcare, things like that, which is something that we need to overcome. I like how you mentioned, maybe doing trials just in Black women could be exclusive or too excluding. Yes, but it doesn't mean that we do need to do more. Maybe it's retrospective trials, maybe it's cohort trials, but not necessarily definitive trials to see how we could better care for our Black patients, but hypothesis generating trials to create the questions that we need to better identify in our prospective trials. And then finally, what you alluded to, so what's the perfect setting? The perfect setting is to have equal representation across our trials, but equal may not be 50-50 or 20-20. Right. Equal may be at least an appropriate representation of the population that we see in the general population.
Absolutely.
So for example, the population in the US, 14 to 15% of the US population, is made up of Black individuals, Black men and Black women. To your point, if the trials are hitting the mark of 5%, they're 300% lower than they should be.
Right.
They need to do, because we want to make sure that the results of the trials are transferable across the populations that we treat.
Absolutely.
So we're doing more and more to get there. Some of the more recent trials you'll see are approaching that mark, but we're not there yet. We're not there yet. And until we get there, we have to look at the results of the trials with a little skepticism to say, yeah, it works in women, but we want to make sure it works in Black women as well.
Absolutely. And this is my PSA to piggyback off what Dr. Slomovitz was saying, is that we need the participation. And so on the not onus, but as advocates for ourselves, when we go to our doctor, ask questions. Ask, are there any clinical trials that I might be eligible for? And for the medical community, I would implore that you ask and tell your patients about clinical trials, right? Sometimes because they're not eligible, they think, well, I'm not going to mention it. And I think that's kind of that miscommunication where patients miss the mark, where they're not asked, and so they don't know that there may be that a clinical trial exists, maybe if not even eligible for it.
So let me just comment, if it's okay, let me comment on what you just said. You're right about asking for clinical trials. And it's not only asking for clinical trials at the beginning of treatment, it's making sure that you're comfortable with your doctor's opinions and not being afraid to get a second opinion or a third opinion. Because, even if there's a level of comfort, it doesn't mean you don't have to get treated by him or her, those doctors. It just means that you're getting a second opinion that'll make your heart more comfortable that you're at the right therapy, you're getting the right treatment you need. And that's where part of the conversation with the doctors you're interviewing should include the opportunity and the access to clinical trials. So it's bigger than just ask your doctor about trials.
Right.
Ask your doctor. If you're not happy, get another opinion. Again, it doesn't mean you have to get treatment elsewhere. It just means you're getting an opinion you're your own advocate. Tiffany, you do a great job leading an advocacy group, but all you can do is encourage the patients that watch to be their best advocate. And that's why we need your type of leadership.
Absolutely. Thank you for saying that. And that's so true. I think second opinions, and I do think I can even say my own mother's case, it's almost like she felt like she was betraying her doctor if she went to someone else. Like, I don't trust what you're saying. And I in my opinion, again, the medical oncologist was like, no, please feel free. Go get a second opinion. Like, I'm open to that. And so those are the kind of conversations that we need to have. And we were just talking not too long ago with other patients and supporters and advocates that they become your family. Your oncologist is family for you, not only the patient, but for your caregivers and loved ones as well. So you want to make sure that you're comfortable with them, because it's a journey. Right.
Yep, exactly.
It's a long journey. Exactly. One thing I'll also say too is that I think, which is important, especially in the Black community, is that we often hear, I know I do, Black women early on in their journey, that their symptoms were dismissed, that they weren't referred to an oncologist till later. They were told it was just part of menopause or, part of the change of life. And so how can providers better combat this implicit bias in the exam room? You kind of talked about that a little bit earlier, but if you could give rising, even current, up and coming medical oncologists out there, what type of advice and knowledge would you give them in terms of how to approach, and I think, of course, you treat every patient the same, but if there are these the historical factors that influence the way Black women interact with health providers in general, what advice could you give for a cancer patient or someone that, or even a primary care?
Yeah. And to your point, I mean, I think a lot of patients referred to us with cancer are coming from their primary care doctor or their benign gynecologist, things like that. We've got to take all symptoms seriously. Any postmenopausal bleeding should be worked up appropriately. Any abnormal bleeding in a premenopausal patient should be worked up appropriately.
Right.
A normal ultrasound with abnormal bleeding doesn't mean you don't do a biopsy. You got to do a biopsy. You also have to require, and I don't say demand, but strongly encourage appropriate follow-up. We don't want patients to be lost in the healthcare system.
Right.
And then, once we're communicating this message right now to your audience that's going to watch it, it's not just them saying, okay, yeah, I get it. It's them educating their peers. It's them educating their colleagues. They're nurse practitioners, right? A lot of times nurse practitioners are the primary care providers or their PAs. So it's really educating ourselves and then educating the others to help identify those symptoms that would require more of an aggressive workup. And again, particularly in our underrepresented populations, because a lot of times maybe inherent biases allow for a situation that some of their symptoms are ignored.
Absolutely. And so I know I don't want to take up too much of your time because I could keep you all weekend and be recording, but I'm going to give you the final floor. And I think this is important because I know personally how passionate you are, not only about endometrial cancer and cancer awareness and finding a cure, but I do think you understand, which not everyone does, how important this is to organizations like ECANA that specifically know the Black woman experience with this disease. So this is Uterine Cancer Awareness Month, known as UCAM June. So what is the biggest takeaway? If you could have the main stage, which you're on right now, is ECANA, what would you say to Black women in America right now about this disease and how we can push the needle forward?
Okay, great. Thank you I love that question. I'm going to break the question up into 3 answers.
Okay.
The best way to treat cancer is to prevent cancer. So for all patients, maintaining a healthy lifestyle, weight management. I'm a big fan of the injections, or Weight Watchers, or having an active lifestyle. But obesity is a huge risk for this disease. There are some biases. Sometimes women of lower socioeconomic status, they can't eat as a healthy meal because they're more expensive.
Right.
But we need to focus on that. So number 1, prevention. Number 2 is making sure they get the best treatment options, whether it be standard of care or through clinical research, and making sure that the clinical research studies include the appropriate amount or equally represent the populations that we serve, and that there's the best access to those trials. And then when the results come out, we could make sure that the best access to those drugs that make a difference. Third, and equally as importantly, is survivorship.
Yes.
Living with cancer, living with the diagnosis of cancer, making sure we educate our patients on what they can do to get back to their normal productive lifestyle. Make sure that they understand what life after cancer is like, whether it be getting back to work, getting back to their social aspects, whether it's sexual health, whether it's exercise health, all those things are important. And not only that component is for the patient, but for their family members as well. Absolutely. So I think prevention, best treatment, and living with cancer are the 3 areas that we need to better for all of our patients. And again, as I always say, particularly in those women who are from less represented backgrounds and diverse backgrounds.
Well, Dr. Slomovitz, I can't thank you enough. I am officially naming you the Global Ambassador of ECANA because you are just amazing in the work that you do and for endometrial cancer awareness. But no, honestly, I really want to thank you so much for taking your time out. I know that this information is going to help a lot of women out there who are newly diagnosed, who are going through their treatment, or those of you, and I always talk about this as well, that your gynecological health, to me, this is just a personal opinion, starts when you're born. Because you're born with your organs when you're there. So taking care of your health should start when you're born. We should be able to talk more freely about it in our families, especially in the Black community. And again, I just want to thank you so much, Dr. Slomovitz, for being here.
Thank you very much for having me. I appreciate it. I'm happy to talk with your group anytime. I really appreciate this opportunity because I'm passionate about education.
Absolutely. Okay.